Hey guys, this is USM Easy here, and today I'm going to talk about what you need to know for step 2 on thyroid nodules. So here's a sample question stem. A 22-year-old woman presents to her primary care physician after finding a lump on her neck. She denies any fever, flu-like symptoms, or sick contacts. She also denies any pain or discomfort in the neck. However, she notes an unintentional 8-pound weight loss. She does not have a significant medical history. Family history is significant for medullary thyroid cancer in her mother and parathyroid hyperplasia in her maternal grandmother. Physical exam is significant for a fixed hard mass on the right side of the thyroid. A thyroid stimulating hormone is decreased, and a thyroid scintigraphy is scheduled to be performed. So what you want to look for when you're thinking a thyroid question is that there's going to be some physical exam finding on her neck, although this does need to be present. Another way the question can tell you is if they find some sort of nodule on neck ultrasound. In addition, what you're trying to really determine in these questions is how dangerous is this thyroid nodule to the patient? Is this just a benign process like an adenoma or a toxic goiter, or is this something that can be malignant? This patient has some symptoms that are quite concerning given the weight loss and the lack of pain. In addition, her thyroid stimulating hormone level is decreased, suggesting that this is a cold nodule. So we'll talk a little bit more about what we're going to do on workup to figure out what this is. So what you want to look for in these questions is that we want to confirm that there's a thyroid nodule. So there'll be some finding physical exam. An ultrasound may see something as well. If the TSH level hasn't been checked yet in the question, that is the first thing you want to do because that is going to guide management and diagnosis. And during your workup, you want to figure out whether this is functioning or non-functioning, and we'll talk a little bit more what that means and whether this nodule is either benign or malignant. So given the workup, so let's say the patient presents with a thyroid nodule. The first step you want to do is measure the TSH and determine whether it's high or low. If the TSH is high, that generally signifies that the thyroid is very active. It's being stimulated a lot. So what you want to do in these cases is you want to go directly to an FNA biopsy because this sort of process is very suspicious for possible malignancy. If the TSH is low, however, that could signify that the thyroid is actually making a lot of hormone, which is suppressing the TSH level. As you can see right here, when we do an RAA or radioactive iodine scan, we are going to determine whether it is a cold nodule, which refers to the thyroid having decreased uptake relative to surrounding, or a hot nodule where the thyroid has an increased uptake. And I'll show you that on the next slide. If it has an increased uptake, we are going to measure the T3 and T4. The reason why we're doing this is we're suspecting that part of the thyroid nodule is very hyperactive and creating a lot of hormones. So we're just confirming that this patient is in a hyperthyroid state. If the nodule is cold, however, that signifies that that nodule is not active and not creating thyroid hormone, which could be suspicious for malignancy. So then we move to the FNA biopsy. Hot nodules will have increased uptake relative to the thyroid, so you'll just see an area that looks dark compared to the rest of the thyroid. In contrast with the cold nodule, which will show decreased uptake compared to the rest of the thyroid. These tend to either be toxic adenomas, usually benign. If there are multiple of these focal signals here, you can think about a multinodular goiter. For cold nodules, these are more suspicious for cancer, so these have to be biopsied immediately. Now I just want to briefly talk about the different types of thyroid cancer. The most common being papillary, which has the best prognosis, and the least common being anaplastic, which has the worst prognosis. Follicular is somewhere in the middle. Follicular is important because it's one of the carcinomas that spreads hematogenously. There are a few others, including HCC. And the reason why I've color coded this is that the ones in orange come from the actual thyroid cells, while the medullary carcinoma comes from the C cells. So after on ultrasound, I think one thing that's important is that the thyroid nodules can be classified on ultrasound whether they are suspicious or not. So if a thyroid nodule is greater than 1 centimeter and has one or more suspicious features, including irregular margins, which this one shows here, microcalcifications, or extrathyroid extension, this is already an indication to remove the thyroid nodule without even giving the diagnosis on biopsy. So continuing off of that, if the biopsy comes back clean, it's not suspicious, it's not increasing, you're just going to do ultrasound monitoring. If a biopsy is indeterminate, you got to repeat it. If the nodule is suspicious for malignancy, either on biopsy or on ultrasound, you're going to immediately proceed to removing the thyroid tissue. And obviously, if the biopsy comes back positive for malignancy, you're going to do a thyroidectomy. So, in summary, thyroid nodules, measure the TSH first, figure out whether it's hot or cold, and think about the different types of cancer and risk factors and what you want to do for management of these patients.